Okay, guys. So we start the first medicine theory session. So good morning, everyone. I thought I'll start off with the structure of the supplementary examination. So this I got it from the handbook. So we will be having like CQs, MCQs, and long case and short case. So what we will try to do, what we will try to do is like try to cover up the theory component and the practical component. I heard that the medicine feedback is happening on Friday. So after Friday, like we will have a poll where you guys can vote whether we should focus more on the theory component or the practical component. And so for the theory component also, we will be touching on the long case discussion. And basically the points which should be elicited in a history and the examination for relevant examination findings followed up with investigations and management. And for SCQs, mainly we'll be covering on how to like approach answering SCQs and SCQs, because I think like personally, like you can score a lot through the SCQs, like if you like answer them very well. Even though things like MCQs and all, they get very repeated a lot. I think things like now true and false are basically like direct theory questions. And these things like they can always come up with new stems. So it can be very unpredictable at times. So like I think paying more weightage to the SCQ and, writing a proper SCQ answer will yield more benefit than perhaps in doing MCQs, but we will cover MCQs as well. So true and false is direct theory, and personally, like it's very unpredictable on what they ask. And most of the time, all 5 stems of a true and false MCQ we will not be able to answer. And single best response SBR. Single best response questions are basically like an application of theory. So we will also see how to approach them and how to exclude certain stems and how to come up with the correct answer. So mainly we will be focusing on the long case discussions, SCQs, SBA, how to approach, and yeah, maybe some true or false questions also at the same time. And practical component once again, so this should be practiced in the wards, in the ward setup. So long case, mainly it's how to manage the time and what to ask the patient, and mainly how to present. And short cases examination also, like when you guys go to wards, we'll come with you all, and then you guys first practice the general format, and then myself and some others will be assessing the technique and how to interpret clinical findings, and how to time it, and basically how to present. And personally, like I think when you do like 10 when you practice CVS examination like 10 times, the flow comes very naturally. But when it comes to presentation, it can be a bit difficult because different patients will have different presentations. So we will do some simulated short cases also in the ward with the time to come. So that's what we hope to cover. And when it comes to medicine, I think this is very important. First of all, like I think 2/3 of medicine is basically must know knowledge, and there's a lot to cover in that. So these are things which are like essential and fundamental, and it's very important that we know the must know things, and there's a lot of must know things. And personally, like I recommend reading, at least first studying and then reading these must know things every day, or at least every other day. And then of course there is the good to know things and nice to know things, and then very exceptional things. So personally, I like to swim between these must know things and good to know things, and then if I have time, work on the nice to know things and the exceptional things. Okay, so we will in today's session, since we are also not sure on how to proceed, and we haven't got the medicine feedback form, I thought of just doing some a revision, sort of like a long case approach on chest pain, which is one of the easiest cases. So I'll just give a rundown on what points to elicit in the history and the examination, and then we will talk about a bit of investigations and management. But ideally, how these long case sessions should be done is like ideally a patient must be presented, and then we will have a discussion on it. But since it's our first day, we will just do a quick revision, and then with time to come, we'll get feedback from you all, and we'll arrange the rest of the sessions in such a way that everyone here will benefit. So yeah, okay. So when it comes to any medicine long case, so this is like a format I apply. Everyone has their personal preferences, but this is something that I use for all my medicine long cases. So I have a format where I ask these 11 questions. I always like when you for the exam for the long case, you get the sheet like in a paper. I mean sheets of paper before attempting the long case, before going to the long case, right? So what I do is I quickly jot these things down. So the name, age, occupation, and comorbidities. Even before the presenting complaint, I ask the patient like the diabetic or hypertensive or any known medical pathologies are there. So then I get an idea of what kind of patient this is, and then it's the presenting complaint, and then the HPC. And HPC, this is the most vital component, as you all know in history. So I always start with the story. So story, I just since I need to get a good rapport with the patient, also I'll just let the patient speak for like a minute or two. Trying to listening. I mean, I listen to their story, and then whatever they are trying to say, I try to interpret it, and then come up with some differential diagnosis. And then I also think about the etiology and the complications and any investigations and management done up to now. And then in the systemic inquiry, I will send you all that document also. So we analyze each and every system, and there are like some cardinal questions you should ask from each system, and basically that covers that system. And in the past medical history, surgical, drug history, allergic history, family history, social history, and for social history, the medicine long case, I only ask these things. I mean, I don't take a very extensive social history for medicine like in pediatrics, but for example, some things, in some cases, for example, in a stroke case, it's sometimes better to ask which hand is the patient's dominant hand for things like rehabilitation and all. But those are like very nice to know, good to know things. So I mean, those won't really determine whether you pass or fail a case. So I'll apply this format to a case of chest pain. So basically, same format. So name, age, sex, occupation, where they live. So the patient will usually say, I may papuridilave. So then I'll tell them to tell the story. So what happened, for a minute, how they were, what they were doing, all that. I don't really write those things. So, but I will, in between, I will interrupt the patient and ask, okay, where was it exactly? And, apply Socrates. So the character, whether it was tightening, radiation to the arm, neck, and jaw. And for associated symptoms, I will always ask the cardinal symptoms of the CVS system, because the cardiovascular pathology is one of the most sinister pathologies we have to exclude. So ask about palpitations, syncope, ankle swelling, shortness of breath, and any other autonomic features like sweating, nausea, and vomiting. Then the time and the exacerbating and relieving factors, like was it more on exertion with stress, heavy meals, whether there was a change of weather, things like that, and the severity. So like the things I have highlighted in green here, like you can refer back to the pyramid, like these are like must know things, and these are the things that you must ask, and you will get marks for telling these things in your history. I mean, if you don't tell these things, the examiners will then, prod and probe and like, dissect your HPC trying to get these things. So if you tell these things in one go, like they won't bother asking you again about these things. And when it comes to differential diagnosis, so anyone presenting with chest pain, we can think about the structures there. So it can be something related to the cardiovascular system, something related to the respiratory system, or the gastrointestinal system, and musculoskeletal system is also can be considered. So things like in an exam sitting, we will never unlikely to get a case of aortic dissection. So you can, but you have to show the examiner that you have excluded such a cause. So, I mean, I have a highlight in bold, like you can ask about whether they have felt coldness in the arm, or whether there was a state of collapse or sharp radiating pain to the back. I mean, 2 or 3 questions like that can be asked from the patient to exclude a very sinister pathology. And then things like a pulmonary embolism, so whether the patient had a prolonged period of immobilization, and whether there was whether he coughed up blood, and whether there was a pain during breathing, and followed with the chest pain, whether there was any difficulty in breathing. And of course, if there is a fever with a productive cough, can exclude pneumonia. And when it comes to gastrointestinal pathology, you have to exclude this gastroesophageal reflux disease. So you can ask about long-standing epigastric discomfort, regurgitation of food, and pain associated meals, early satiety, and such. And of course, the musculoskeletal pain, like the pain increases with movements and any history of trauma, so as such. And things like pericarditis. So if it's a known CKD patient, something like that, uremic pericarditis can cause a chest pain. So the cardinal features in this is like it's relieved in bending forward. So you can ask that to exclude things like pericarditis. And of course, the other surgical pathologies like acute pancreatitis also may cause chest pain, but they are lower down in your important list. So, the things I have highlighted in green are like must know things, and things you must ask and say. And I personally like I think even these should be like practiced every day or every other day, so then you guys get the flow. I mean, once you get the flow, it's very easy. It becomes second nature. Then for the etiology, it's basically once again identifying any risk factors. So you can ask these at this point itself, and then add to your past medical history. I prefer knowing what the factors are. Then I know when I come to the past medical history, like what exactly I should ask on each factor. So modifiable, you can again divide it into modifiable and non-modifiable etiologies. So diabetes, hypertension, dyslipidemia, and if it's a female, you can ask about this OCP. And if it's a male, about smoking and alcohol. And you can just add these things, because like in a long case setting, what matters is your time. So maybe sometimes you won't have time to go into detail about each and individual disease, but I think it's worth mentioning that this patient has suppose maybe you didn't have time to go into the amount of alcohol or the amount of cigarettes this person smokes, but telling the examiner that the patient is a smoker, this thing has a history of alcohol consumption, chronic alcohol consumption, is important. And you can always say that, sir, madam, I didn't have any time to ask further. So those are the etiologies or risk factors. Then you can ask about complications. So these arrhythmias, heart failure, and cardiac arrest. I mean, these are very theoretical. I mean, things that we know. But when you ask a patient, you can ask, okay, whether the patient was admitted to the ICU, and whether they lost consciousness, and with the cardiac massage or something like that, whether they told he had been given, or things like that. That's how you come up with ask the patient about complications. And then you can ask the patient about the management up to now. So you can just ask whether they were given any injections, and what happened then, and things like that. I mean, basically the most important thing is how you exclude your differentials, and whether the patient went into a complication, and whatever the patient has been treated, how the patient has been treated up to now. So that much basically covers your history of presenting complaint, where the majority of your marks will be allocated in your history. And then when it comes to systemic inquiry, so we all know, I won't go through much. So basically, there are some cardinal symptoms. So cardiovascular, respiratory, neurological, gastrointestinal, and endocrine pathologies will have to be excluded, but I won't be focusing much on that. And in your past medical history, so if this patient has had previous episodes, it's very important to know some details about it. And also any diabetes, hypertension, any conditions like that will have to be extrapolated in your past medical history here, and any other conditions also. And past surgical history where relevant, you can add. and any drugs the patient is currently on. And this is your family history. And your social history will be about, exercise, lifestyle, how the activities of daily living are affected, and psychological aspects, smoking and alcohol. So that's basically it for the history component. So what I recommend you guys do is just every day, like simulate how you would take a chest pain history, and then this will be very second nature. I mean, you can basically finish up a history of presenting complaint itself in like 5 minutes. So then timing won't be a very big problem. So yeah, and when it comes to the examination, so basically just look at the pain. I mean, if the pain, they won't give patients in pain, and most of the time patient will be pretty comfortable. But just see whether the head end was propped up or things like that. And basically these things, I mean, you don't have to check in detail, but now it all depends on a diagnosis. So this chest pain patient, I'm thinking the probable diagnosis is related to the cardiovascular system. So things like whether the patient is febrile, pale, they are cyanose, things like that. I mean, it really depends from patient to patient, like, but you don't have to check. I'm not saying that you don't have to check, but at the same time, you might not have time, and these things might not be important. But when you're presenting your history to someone, when you're presenting your examination, these things have to be mentioned, because the examiner needs to get a complete picture, and the examiner needs to know that you checked for these things. Whether the patient is in pain, whether he was febrile, whether the patient was cyanosed, whether if the patient is female, whether they have goiter, and the xanthoma. And most important thing is actually the patient has ankle edema, and whether there are any leg scars of any previous surgeries. Yeah, and so another example you guys might have is like so a patient who has come to you all, who is okay now, but who has had an episode before, like who has had an episode of chest pain before, and now a very stable patient. So when you ask for the history, most of the time patient says that I'm not touching it. So in such a situation, what you can do two things, like you can take a retrospective history, like you can before you can take a retrospective history, like you can go back to the date where the patient actually had a problem, and you can present your history in such a way that as the house officer in that particular date, or you can tell currently the patient has no complaints. However, this patient complained of chest pain so and so, and then you can on this particular date, and then you can tell the story now. And in that aspect, this management part in your history of presenting complaint is very important, like how the patient was managed up to now. Like, okay, so after the episode, after the patient was discharged from the hospital, what other investigations he or she underwent, whether any angiogram was done, and how many clinic visits, and the compliance on the clinic visits. Those things are very important, because the diagnosis is already made in a retrospective patient. But if this is a patient who has come for the first time presenting to you, then this your differential diagnosis and things like that, they are paid more weightage, because diagnosis is still uncertain. Okay. So going back to the examination, and basically now for example, like it's most of the time, if you get a chest pain for a long case, like 75 to 80% of the time, it is a case of acute coronary syndrome. So then your examination, you should do a full cardiovascular examination, because the pathology is related to the cardiovascular system. So when we talk about the cardiovascular proper examination, it's always your pulse, blood pressure, JVP, and your precordial examination. So this we will discuss on how to do a proper CVS examination again during our short case session. But basically what we have to check is the pulse, the rate, rhythm, volume, character, collapsing, the pulses are collapsing, and this wall thickness also. Palpation, the precordium, the apex B character, blah, blah, blah. And the most important part here is in the cardiovascular system, the most important part of the cardiovascular system is your auscultation. So if you get a patient with chest pain, always auscultate the patient and give that a priority. Sometimes give that a priority. Sometimes these things in like palpation and all, like this apex beat, heaving nature, thrusting nature. In that stress, you might not be able to elicit all these things. But please, it's very important to auscultate the patient and see whether the patient has a murmur, because most of the time they will have a murmur. It's very rare for them to, it's quite rare for them to give a long case without any examination findings. So see whether this patient has a murmur. Okay. Because for my long case also, I got a stroke patient, and that was a sort of like it happened several months back. And the neurological examination was completely normal, only her gait was abnormal. So it was a cerebellar pathology. The stroke was in the cerebellum. So they always give a long case. Most of the time they give long cases with positive some examination findings, right? So it's very important to really focus down on which examination you must do and do a complete thorough examination. And the respiratory system, you all won't have time to do this inspection, palpation, percussion. So just straight away go for auscultation and see whether there are any crepitations in the lungs. And when it comes to abdominal examination, also not much time, just ask the patient whether he or she has abdominal pain, and maybe, do some palpation and see for any hepatomegaly or things like that. Nervous system, in a case of chest pain, really there is no time. So, most of the time you can ignore it. Okay. So that's for the history and examination. Now, usually after the history and examination, you will have to make a problem list. So what I recommend you do is like you guys can make like medical problems, social problems, and other psychological problems. Under those 3 headings, you can make a problem list. And then summary. So summary, the best way to write summary is to look at these SEQ papers. In SEQ papers, usually they write a summary of the patient, right? So you can, that's how I learned how to write a summary. Because they talk, they really paint a picture about a patient very nicely in just a few words. So you guys look at how the medicine SEQ papers, how they have written, and then just copy from it and also practice. Okay, so when it comes to a case of chest pain, in an exam setting, the diagnosis is usually very obvious, so chest pain, if it's of cardiac nature, it's very obvious. So the patient will have nausea, vomiting, and if you ask the patient, they will say kept in the HDU or something like that, and drugs were given. So they usually, then the examiners will ask, okay, what is your tentative diagnosis? So you can say something like acute coronary syndrome. So then they will go on to investigations and management. So in such a case where the diagnosis is very obvious, more weightage will be on investigations and management. In fact, if you give a good history and examination with a good problem list and summary, they won't be spending much time with you on those regards. They will straight off go to investigations and management. So I thought of just brushing through the investigations and management for acute coronary syndrome. So as you all know, when it comes to, it is a medical emergency, and both investigations and management are done simultaneously. So what you do is a 12-lead ECG, and is there are different regions. So lead 1 is lateral, 2 and 3 and AVF are inferior. And then 5 and 6 are also lateral. V1, V2 are septal. V3, V4 anterior. This is a good to know thing. There will be instances where you all will be tested. You all might be asked, okay, which region of the ECG showed changes in these regions, which region it might be. these are like good to know things. So yeah, moving on. So ECG changes in a case of acute coronary syndrome. So it can be due to an ST elevation, or they can be non-ST elevation. And if the cardiac markers are positive, I mean, if it's an ST elevation, it's a STEMI. And if the cardiac markers are in non-ST elevations, if the cardiac markers are positive, it's an STEMI, and if negative, it's an unstable angina. So these three acute coronary syndromes are different different pathophysiologies. Just read up on them. I mean, once again, I don't think in an SCQ setting they will ask what is the pathophysiology of acute coronary syndrome. I mean, I don't think they will ask, but I mean, don't count on what I say, but it's very unlikely. But just read up on it, because then it's very easy. I mean, these are like good to know things. So if you all read up on it, you will have a better understanding. And also read up on atypical presentations of STEMI. So there are some atypical presentations like new onset left bundle branch block ventricular phase rhythm, isolated posterior infarct, and also read up on how to recognize true ST elevations. So there is a criteria. I mean, these things they will ask and probe if you are giving like very good answers, like if the must know stuff are very good, they will ask you these things, so they can give you more marks. And also read up on scoring systems and how to assess the severity of STEMI, NSTEMI, and unstable angina. I mean, these things, this is like a nice to know thing. So if you all have time, just go through. What I recommend doing is like basically, since there's a lot of things to cover in medicine, know every must to know thing about each disease. And then if you all have time, go on about the good to know things and the nice to know things. Okay. So going back to ACS management, so this is like some aspects of the management is must know things. So how will you approach such a thing? So since it's a medical emergency, it's always good to talk about the setting first. So ideally, patient should be managed in a high dependency unit, or perhaps even ICU admission is warranted if the condition is severe, depending on the severity of the acute coronary syndrome. So you follow the ABCD protocol, and oxygen in this case is a drug. So 2 liters per minute administered by nasal cannula for the first 6 hours. Continue thereafter if oxygen saturation is below 90%. I mean, when you I mean, this is a must know thing. I mean, if you tell it, they know you know a lot about how to give oxygen, which is a very basic thing to a patient who's having an acute coronary syndrome. And then you get intravenous access, and then you do these investigations. Once again, these are like the things highlighted in green are like must know things. And read up on different enzymes and their blood levels against time from insult. So this is like a good to know things. I mean, maybe you will be questioned about these things in MCQs. But when it comes to telling answers verbally and writing SCQ answers, most of the time they test very basic must know things. So you guys should remember the investigations done. And pain management, once again, it's a must know thing, how to relieve pain in a patient with acute coronary syndrome. So you can give morphine along with metoclopramide or sublingual GTN. So this is a very basic overview of management of acute coronary syndromes. So if it's a STEMI, so you give these loading drugs, and then there's a decision between PCI and thrombolytics. And if it's an unstable angina and STEMI, you only give these drugs. These other PCI, this PCI here is like a rescue PCI. So if patient doesn't respond to these drugs, then you go for PCI. So from yeah, and then one more important thing is to know about the time frame for PCI. So usually it's 120 minutes. So a patient comes to you, and if you can administer transfer to a PCI capable hospital in 120 minutes, then that should be done. If the patient is presenting to a PCI capable hospital, so now for example, patient is presenting to the national hospital first person with chest pain, their aim is to administer PCI within 6 minutes or something. So, for example, and if the patient presents with chest pain to Pandura Base Hospital, they will see whether the patient can be transferred to a coronary care unit within 120 minutes. So that's the difference. Okay, so then loading drugs, doses and route. Since it's a medical emergency and one of the most important medical emergencies, should know the doses and the routes. So dual antiplatelet therapy, know the doses and the route. It's there in any guideline. Statins, high dose statins should be given. And so you have to then anticoagulate the patient. So if you are going for PCI, you can use either unfractionated heparin or enoxaparin. So, so if you can know the doses here, sometimes they might not ask. Personally, I don't think it's worth asking a undergraduate medical student what are the anticoagulant doses for PCI, because we are not going to administer PCI. Also, this is like a good, nice to know thing. Usually for PCI, what is recommended is unfractionated heparin over enoxaparin. And but this is no, when it comes to thrombolysis, it's something we should know, because it's something that is done more frequently than PCI. So the doses for anticoagulant doses for thrombolysis you should know. So what we usually practice in our ward is giving enoxaparin. So you should know the doses if the patient is less than 75 years of age and if the patient is more than 75 years of age. And I know the guideline talks about these other drugs like ticagrelor, prasugrel and all. Remember those things if you guys have time. If you have mastered all these drugs, then I think you can remember other drugs like ticagrelor or prasugrel. But they are not really important. They are not. Knowing them won't determine whether you pass or fail. Those are like good to know things and nice to know things. And also the dose of thrombolytic agent. So what is used currently now is tenecteplase. So basically, if you all see, it's basically half of the patient's body weight. So if the patient is 60 kilograms, you usually give 30 milligrams of tenecteplase, something like that. If the patient is 80, you give 40. That's how I remember it. And streptokinase is not really used now, but they may ask you in a long case. So it really depends. So the contraindications for thrombolysis, for my medicine emergency viva, they normals asked me about this. Absolute contraindications. He actually asked me almost like all of these. And then he asked, tell me some relative contraindications. So I couldn't remember this entire list. I only remember 3 and 4, and 3 or 4. He was like, okay, that's enough. So just remember the absolute ones and some of the relative ones. Okay. So if you have come up to here in your case, it means you have done very well. So assessment of the reperfusion status. So you can think of a patient who has been given thrombolytic therapy, how the patient will respond. So one thing is the chest pain will go down, and then the patient's hemodynamic stability and electrical stability will improve. And then this is once again good to know thing. So more objective measurement of how good the effective the thrombolytic or PCI therapy is, complete resolutions of the ST segments. So I'm discussing in a case of STEMI. So they have become more than 70%. If there is complete resolution, more than 70% of the ST segment elevation will go down. Okay, then the next aspect is secondary prevention of any coronary event. So basically, these are things which they can ask in an SCQ setting also. So basically, you can have some certain headings. So non-pharmacological and pharmacological. And non-pharmacological talk about smoking cessation, cardiac rehabilitation and all. And you can always if you want to speak more about it, you can even add that ACE model, which Niels taught in psychiatry for smoking, or the STAR model for helping smokers to quit smoking, things like that for extra marks. And then your antiplatelet therapies, beta blockers, statins, ACE inhibitors, and this is the mineralocorticoid receptor antagonist is a new thing which is now used in the case of acute coronary syndrome. So this is a typical prescription. You all can go through this leisurely. And management of complications in STEMI. So basically, these are some of the possible complications. So if you are like a really, you have done your case really well, they will ask, okay, how to manage each and every complication. So with time, we will go through these one by one, how to manage left ventricular dysfunction and how to manage this cardiogenic shock along with atrial fibrillation. So these are like, these are things, these are good, nice to know things or good to know things related to the chest pain show on a long case. So as homework, you guys can do a similar sort of thing, like, have a management outline, management of STEMI and unstable angina, and the management of stable angina. So you guys can refer Kumar and Clark and read up on any guideline. So feedback after Friday is like, we'll be having a poll after Friday, and you guys can vote on whether where after the feedback, you all will know whether it's the theory component or the practical component which you all have gone down. So then we can like arrange sessions depending on that. Okay, that is that. And one more thing is, I sent some, Hiruni sent me some cardiovascular SCQs. So I just wanted you all to show like these things like SCQs and long cases. I mean, there's a lot of overlap between them. And so basically this SCQ, the first one, long-standing history of hypertension, presenting with progressively worsening shortness of breath and ankle edema. I mean, you can say, like, tell it from here itself, most likely it's a case of heart failure. So, and usually what they are, when it comes to questions, what they ask is, what they do, I mean, when it comes to medicine SCQs, what they do is usually they give some story. The most important thing is to the first thing to do is identify which system is the story from. I mean, that's what I did. So, I mean, from this information, I can say shortness of breath with ankle edema, and with the rest of the history, most likely the story is related to the cardiovascular system. So once you figure out the stories from the cardiovascular system, then try to figure out from what is the pathology, like so for like when it comes to our medicine syllabus, when it comes to our cardiovascular system, either they can question us about arrhythmias, acute coronary syndrome, hypertension, heart failure, infective endocarditis, are like hot topics for SCQs. But from that, the history given here, it's most likely that it's related to the heart failure. I mean, so once you identify that, then you just have to remember what the things you know about heart failure. So, for example, like list 4 etiological factors. I mean, that is direct theory, and 5 precipitating factors for heart failure. Again, direct theory, and you can always, if you get a patient with stable chronic heart failure for the long case, I mean, these are the same things you will ask in your history also. And these 3 investigations, and outline the management. So what I recommend you all do is like for each of these topics, for the hot topics for SCQs, like arrhythmias, acute coronary syndrome, hypertension, heart failure, infective endocarditis, like have like a outline for y'all, like what are the investigations you will do and how will you manage the patient, and like every day, like work on, I mean, refine your investigations and management, because like medicine is like a lifelong thing. I mean, as you all go on, you all will be keep adding more investigations and more findings in those investigations, and refine your management. So yeah, heart failure, that is heart failure. We will discuss these things again. I'm just telling you all like a general guideline. and 68-year-old male presenting with 2 days of palpitations with no previous history of cardiac disease. So whenever this palpitation business comes, I mean, definitely either the pathology is cardiac or something psychological. I mean, that's what comes into my mind. So, and then they give the story of an irregular pulse. I mean, then, I mean, one of the commonest causes of irregular pulse is atrial fibrillation. So then, you know what it is. Then basically what you guys should do is just try to remember some of the investigations and how to manage atrial fibrillation. What I'm trying to show is like all these SEQs have like a very common, outline they all go by. So yeah. So what I recommend you all do is like try to answer these questions and then we will discuss them in due time. That's it for today's session. Do you guys have any questions or any feedback or any ways of improving these sessions? I mean, is it useful? Like, since it's our first session, we are also like not sure.
Yeah, Matish, it's useful. Like
Okay.
something like this would be good.
Okay, so there are some questions posted in the chat. So how to answer that SEQ? Yeah, I think first the most important thing is when it comes to SEQ answering is having the knowledge ready. Like you guys have to be thorough on the must know things about that topic. So we will get into that in time. But like now I told you all like how to. I told you about the chest pain long case, no? And I told you some must know things about acute coronary syndrome. So in the meantime, we also teach how to do it. You guys also like make your own must know things about each, like hypertension must know things. Management, what you think you must know, you guys write down, and then you guys can compare it with us when we do a session on that topic. And then you all can add or subtract some of the things which are not necessary. And it's best if you all get a history from a patient and then we can discuss it, because at the end of the day, I mean, the most unpredictable component in the exam is the practical component, because patients can be very difficult and you have to manage the time and all that. I mean, studying part is actually we can control it, right? But we can't really control. When you go to the exam, we can't really control the patient. So in the management, what points? So it depends on the case and it depends on the state of the patient. So, but generally, if I talk about management in any medical management, there is an acute management and there is a long-term management. And in the acute management, it's mainly how you position where the patient is going to be managed, which part of the ward, and then maybe how the patient is positioned, and then any additional equipment that might be needed to the patient, like CPAP machine, high flow nasal cannulas or things like that. And then basically acute management is basically drugs, drugs which work quickly. So you should know about the doses and the routes. And then when it comes to long-term management, it's always better to start your answer saying, this multidisciplinary team, because most of these medical long case problems are, it's going to be there for a while. So best to do it in a multidisciplinary team, maybe in a specialist clinical. So if someone talks, I mean, if I get a case of ACS and if someone asks me the management after giving the acute management and the long-term management, I would say, oh, this patient ideally should be managed in a special coronary care unit under a consultant cardiologist. And with that, there might be the need of rehabilitation people, occupation people, physiotherapists, and things like that. You can keep on adding. And then after, I mean, when you give an introduction like that, you can then talk about the non-pharmacological. I mean, that is, stop smoking, reduce alcohol consumption, watch out your dietary habits, exercise, stress management, things like that. And then come to your pharmacological management. I mean, if you are, I mean, that's the, sort of like the skeleton I use for long-term management. So first I always talk about some multidisciplinary team, and then I talk about the non-pharmacological management, and then I talk about the pharmacological management. So yeah, MCQ sessions will happen. We are also still preparing because thing with MCQs is like you need like a lot of knowledge is needed to attempt MCQs, especially these true or false ones, because they are just direct theory. And this time the medicine MCQ true and false also I found it very difficult because they have asked from here and there. But we will definitely have some MCQ sessions as well. So what I thought was maybe do long cases and SCQ first, because those are like they really test the must know things, and they are like very basic theory component. And then as closer to the exam, we will do these MCQs, true and false stuff, and SBRs. Yeah, so that's it. You guys, if you guys are going on Friday to UHKDU for the feedback thing, maybe you can, I think there are like if you can like maybe take some histories and then we can discuss it. As far as I know, the Friday session will be done by Chiranta. So he will post which topic he's going to do on Friday. Then you all can prepare yourself for it. And then we'll have that poll also on Friday. Okay. So then, shall we call it a day then for medicine?
Thank you, Matisha.
Okay.
Thank you, Matisha.
Okay.
Thank you, Matisha.
Sure.